All right, guys, can you hear me okay?
Yep, I can hear you.
Okay, perfect.
Okay.
So for those of you that have been with us, you know that my internet's not great. So if I ever cut out at any time, just let me know and I'll either turn off my video or I'll do some troubleshooting. I've had like the hardest time with AT&T, so it's been kind of a mess. But um, we'll kind of troubleshoot it together, basically. Okay. So, my name is Emma. I'm a fourth year medical student, last rotation, about to graduate. So, it's been hopefully a lot of downhill for me at this point. Today, we're going to kind of talk about something that I think is a little more laid back than the regular sessions that I have kind of taught in the last few times. We're talking a little bit about screening guidelines and kind of, these things that we implement in order to prevent something from happening, basically. So we call that primary prevention. So the things that you probably know about, like pap smears and mammograms and different things that you may not know about. But we are going to kind of go through those things. I'm going to teach them to you, and we're going to go through a few cases that kind of touch on that as well. Okay. And I'm putting this into the chat right now. That is the kind of SOAP note and the quiz. So you'll have access to all that to kind of go through and fill out throughout the session today. Me before, you know that I like to make the poll available to you all um, in order to really kind of gauge where you guys are at right now. And I really suspect you guys know not a lot about screening, and that's okay. Maybe you know a few of these things if you've been screened in one regard or another, depending on your age and your own risk factors, or if your parents have had these screenings or your grandparents or whatever. But we'll give a couple more seconds. There's a couple of you out there that haven't answered just yet. All right, so let me share the results with you all. It looks like the kind of majority of you guys say you know nothing, which I think is completely okay. I think I didn't know the majority of my, screening guidelines until, I was in medical school myself. Let's see. We'll stop sharing this and we'll keep going here. I just have trouble moving around all these bars. There's a bunch of bars in the way. All right. All right, so as I kind of talked about before, what we're going to do is we are going to talk about the USPSTF screening guidelines. I know it's like an alphabet soup, basically. So we're going to primarily focus on that because that is the U.S. Preventative Services Task Force. That is, the kind of governing body of which is in place in order to make sure we're kind of doing these primary prevention things. And this is a lot of kind of primary care stuff. So if you're interested in that, this might be the talk for you. Then we're going to kind of go through 3 cases. I'm going to give you a patient and we're going to kind of discuss, based on this person's risk factors, based on, their age, gender, their history, what are the tests of which are important for this patient. Okay. And that's how it's going to be in real life. You're going to have patients that come to you with, a certain history, and you're going to have to decide, what preventative things you're going to need to do for that patient. And what's your guys' role today? I want you guys to, like last time, like always, fill out that SOAP note. I just put it in the chat again in case you missed it. And then also actively participate and, read questions, do all of that, so that we kind of have a good discussion throughout the, the talk itself. You might be wondering who this guy is right here. That is our foster dog, which we have sort of exceedingly failed at fostering, and he's now our dog. So that's him. He is a mess. He's crazy. Not near me this time. I know if you guys were with me last time, you probably heard the dog being crazy, but That's him. His name is Ari. He's absolutely crazy. All right, so here's the SOAP note. It's going to be, a little bit, we have to have a little bit of flexibility this time in terms of the SOAP note, because the SOAP note obviously stands for SOAP. It's subjective, objective assessment and plan. Subjective is things that the patient kind of tells us. Objective is things that we kind of find out. Assessment is what we're going to do, and then plan is assessment is kind of what is going on, and then plan is what we're going to do because of that differential diagnosis, that plan. So today it might look like something like, subjective might be 40-year-old female, presenting for annual wellness visit. That's the subjective part, because we don't have a lot. You can make up an ROS and say like review of systems negative unless otherwise specified. So that's your ROS, that's your HPI, so the reason why the patient's coming to see you, and then the ROS, the review of systems related to their chief complaint. So in a wellness visit, they're not really coming with an ROS unless they have a kind of concern to talk about. Objective, might be, things that we find on exam, and vital signs. You can kind of fill that in as it kind of comes in terms of this talk. And then assessment might be, the first might be health maintenance. So because there's really nothing else going on, health maintenance, we might put, or if they abuse tobacco, we might put tobacco use or abuse. We might put that as one of our assessments. And then our plan, what are we going to do for health maintenance? We might say, okay, she's a 40-year-old female, mammogram screening recommended. We'll put in order, or whatever we're going to do. So basically what I'm saying today is that your SOAP notes may not be as extensive as usual, just because of the nature of the talk, and that's totally okay. I don't want you guys turning in like blank things though. Just be sure you kind of put something, and if you kind of adds additional details in, that's okay. This is for your practice though, so I don't want you to be stressed out about it either. But definitely add something in there in order to kind of fill in the actual SOAP note. And then once you get to the quiz, I think it's fairly easy from that point. Okay, so like last time, I would appreciate, just to kind of see where you guys are at, go to the kind of annotate button, click on the stamp tool and let us know where you're at. There's always lots of people from Canada. I love it. We have California, 2 Californias, cool. Lots of East Coast, some Floridas, Tennessee. Awesome. All right, well, wherever you guys are at, thanks for coming. I always, like talking to you guys on these Wednesday nights. And I think you guys will like this session. It's pretty chill. We'll learn a few things. We'll keep it simple, okay? So the first thing that we're going to kind of talk about right now is this idea of, what are these screening guidelines? So what you'll see, and let me kind of stop sharing for a second, or at least get out of the PowerPoint mode. Let me put this up here. You guys know a better way, basically, kind of like, I'm borderline old. You guys are much younger than me. Okay, so basically, here is another link for you all, and that's to the USPSTF. And as I kind of said, it's the U.S. Preventative Service Task Force, and it sounds, probably a lot cooler than it really is. But basically these are the people that say, here's what we recommend. This is why we recommend. And it's kind of a governing body for physicians to follow. Okay. And so what we're saying is that the USPSTF, this governing body, is going to give a rating to these recommendations. Okay, they're all kind of listed out, and if you click on that link, you'll see them. And on that link, though, I've given you A and B recommendations only, and those are really kind of the important ones to kind of remember. And those are the ones that are most often implemented in practice. So those are the things you see, like pap smears and mammograms and these things that you've kind of heard already at this point. So all that being said, we're given a letter to these things. And on that document, like I said, that's A and B recommendations. So basically what we're saying is if it's an A recommendation, there's a high certainty that there's a benefit for it. Okay. If it's a B recommendation, the net benefit is moderate, or there's a moderate certainty that the benefit is therefore substantial, basically. And what do we do for these things? We offer or provide these things for patients. Okay. And it gets a little tricky when we get down to this C recommendation, where it's kind of selective. And you can look up on that website, what these selective offerings are, but basically what we're saying with these recommendations is that implementing these into practice means that there's kind of a plus or minus certainty that there's a small benefit to including them. All right. And then the other things that we kind of see is this D recommendation. If it has a D, that means there's not a benefit, and it kind of USPS recommends against the service. And then the I that you kind of see at the bottom, this one is basically there's not enough evidence. So we don't really know. And so for D recommendation, we kind of discourage it. And then for I recommendation, it's more of kind of a conversation and kind of balancing risks versus benefits. So the I recommendations might be some of those ones we see in terms of research-based and things along those lines. Okay, so there's not a true guideline or recommendation for them, but it's still kind of, lingering there. So I want you to have a little bit of that context. And as you're probably scrolling through those recommendations, you're probably seeing that, you may have seen some of these things that are recommended. And we're going to go through some of the big ones now. Okay. So the first one being abdominal aortic aneurysm. And for those of you that are scribes or, have worked in a medical office, that's bad. And we've talked about this a little bit when we talk about the aorta. I talked about the aorta a while ago. And if you missed that talk, you can go back on our YouTube channel and watch AAA and the talk about the actual aorta. So who do we recommend screening for AAAs for? People who have a risk factor for it. And what's the risk factor for it in this instance? It is people of whom, and specifically men, and we'll want to, sort of hone in on that. But the recommendation in this regard is for men, and not just any men, but men of whom have, or 65 to 75, who have ever smoked. Okay. And that's the important thing to kind of remember, the kind of smoking history. So if you get a man of whom is 64 years old and comes in, we'll say, okay, is there a big difference between a year? Maybe not. But the insurance will cover it at sort of 65. Okay. So 65 to 75 who have ever smoked. So if you smoked 2 cigarettes, that sort of constitutes as well, though, primary care physicians will be less likely to pull the trigger in that regard. The one that we look at where PAC years matter, which when we talk about PAC years, what we're kind of talking about is how many years that they've smoked, how many years, and times the number of packs. Okay. So that being said, so say number of packs. This is a lot harder to write like this than you guys probably think. So bear with me. So basically This is what the pack years are, and it's as simple as that. Okay, so say as a kind of exercise, I say our patient Jimmy has smoked for 13 years and has smoked 2 packs per day for 13 years. How many pack years does this gentleman have? Perfect. Good. It's as simple as that. Easy math problem. I can even solve that one. So good. So what we're talking about in terms of lung cancer screening. So now we're kind of pivoting a little bit and we're talking about lung cancer screening. What we're talking about here is basically, so here's our lung cancer screening. We're talking about adults. This is not just men, it's adults age 50 to 80 who have a 20-pack year history of smoking or have quit within the last 15 years. So remember, there's an or statement here. So 20-pack year history and currently smoke. So that's current. So I'll separate this in colors because that's how I kind of think in my head. Okay. So 20-pack year history and that's current, or they have quit in the past 15 years. Okay. So you have to remember like 3 things here. 50 to 80, any adults, not just men, 50 to 80, 20-pack year history, who smoke currently or have quit within the last 15 years. Okay, that's what we're remembering here. All right, and what we do for that, we send them for a low dose CT scan, and that's basically looking. That's a low dose of radiation to the kind of lung, and we're looking for nodules. We're looking for incidence of cancer. And when we talk about cancer in smokers, we're talking about primarily 2 things: squamous cell carcinoma and small cell carcinoma. And basically, the way oncologists often look at lung cancers is small cell versus non-small cell, because they're treated very differently. Okay, so that's our first recommendations. And the image in the upper, that was horrible because you can't see that. The image in the upper right-hand corner here is kind of shows the incidence of an abdominal aortic aneurysm, of which was caught on ultrasound. Okay, so let's keep going here. All right, so here's our next ones, and this is kind of focusing more on women. And the first one is breast cancer screening. All right. And this is where it gets a little fuzzy. And we're going to talk about this in the next slide as well. So there's 2 governing bodies that often kind of, like the, blood or the blood pressure guidelines, how American Heart Association and, American Heart Association and, cardiologists kind of go back and forth and talk about these guidelines. The USPSTF and ACOG, which is American College of Obstetrics and Gynecology, go back and forth about this as well. And I'll show you this in the next slide. But for simplicity's sake, when we talk about mammograms, what we're talking about, what USPSTF recommends is biennial screening. Okay. And that's women 50 to 74 years of age. So this is every 2 years, and starting at 50 and then going to 74. And we'll see where this differs in a few minutes as well. Then when we talk about cervical cancer screening, and what that is a pap smear basically for women. And the way that on the boards or just in general in life, people like to trick you is if women are sexually active even before the age of 21, it's still not indicated to have a pap smear until they're 21. Okay, so remember that. But ages 21 to 29, what is recommended is every 3 years with cytology alone. And what that means is that the provider does a pap smear with the brush and gets enough cells from the cervix. And what the pathologist does is look at it underneath a microscope. Okay. And what we're seeing is this. And hopefully it's not this actually. So these are kind of normal cells over here. We see normal koilocytes. And then over here, we see kind of, abnormal cells where the nucleus to cytoplasmic ratio is pretty increase. Basically, it's almost like a 1-to-1 ratio, where we see over here there's a lots of cytoplasm, and the nucleus is here, whereas here this is kind of bad, and those are high risk cells, and that's when a pathologist will report that back, and they might say, I recommend colposcopy to get tissue in order to test. Okay, now the other thing that's recommended is for women ages 30 to 65, either the same thing that we had done ages 21 to 29, which is cytology every 3 years, or co-testing, which is the human papillomavirus DNA testing with cytology. Okay, and that's what most people will do. They'll do co-testing with HPV DNA or HPV DNA testing in combination with cytology. So they're doing a PAP, also testing DNA as well. So basically, if that's negative, then every 5 years. If this is negative for cytology, then every 3 years. And there's obviously, it gets a little hairy when we kind of talk about what if it's positive? What if they have a colposcopy? We'll leave that out of the discussion today for simplicity's sake, in terms of talking about guidelines. That's what I want you to know is, ages 21 to 29 every 3 years with cytology, which is the PAP, and then for ages 30 to 65, then we're doing the DNA testing for HPV, human papillomavirus, and cytology, which is co-testing. Okay, and then what we need basically is 3 negatives to stop by age 65. Okay, I know that's a lot, and it's kind of complicated to remember all these things, but it kind of comes with lots of exposure. And if you guys have that page up in terms of the USPSTF, that can certainly help you throughout the talk today as well. Okay, so this is what I was talking about in terms of the ACOG and USPSTF. Okay, so oops, drew a random line. So what I was really kind of alluding to here is these 2 rows right here. That's ACOG, and here is USPSTF. And you'll see the kind of contradiction. So ACOG says offer at 40, but not any later than 50. So you can see, a lot of obstetrics and gynecology physicians, they're saying, we should offer this at 40, but definitely no later than 50. And USPSTF kind of says, okay, we can start at 50. Then it's pretty similar. They say stop at age 75, and then USPSTF says 74, and then ACOG says every 1 or 2 years, and then USPS says every 2 years, that biennial. Okay, and there is a little bit of difference, and you'll see, depending on the primary care physician, depending on whether the patient goes to GYN for their pap smears and their mammograms. A lot of physicians will start at 40. A lot of women will want to get mammograms starting at 40, and a lot of this comes kind of in combination with shared decision making between the patient and the physician. Okay, so that's kind of the what we see in terms of the, not really contradictions, but people may use one or the other guidelines depending on the patient's preference, depending on provider preference as well. All right, let's keep going. I think I have one more set of guidelines, if I'm not mistaken, to talk to you about, and then we're going to kind of go through some cases here, and you're going to tell me which guidelines are kind of recommended. And remember, that's how the quiz is as well, so you want to pay attention here. And what we are kind of talking about in this one is depression, and depression and hypertension. The kind of screening for them are pretty similar in that USPSTF says, let's screen the general population for these things. In terms of hypertension, it's adults 18 years or higher. And the other thing is USPSTF in terms of hypertension says we're not basing the treatment off of one number, and especially not one number or multiple numbers in a clinical setting. We'll want to do ambulatory blood pressure monitoring. And you'll kind of see that abbreviated sometimes like this: ambulatory blood pressure monitoring. So you'll sometimes see it like that. But that's where, you have the patient bring in their blood pressure log and we kind of look at it and we say, okay, maybe it's only high here, or, it's only high at this time or only high at that time, to kind of correlate to see if we actually need treatment. Because, yes, hypertension can be bad, but so can hypotension. That can cause, an ischemic stroke or, among a number of other things, or, shock liver, lots of other things. The other thing is depression. We often screen people in terms of depression with one test. Do you guys know what the screening test is for depression? It's a set of it's a set of letters and a number. You may have even filled it out yourself at a doctor. So it's close. So DSM is kind of our diagnostic manual, basically, with all the codes and stuff that we use. PHQ-9, nice, Emily, perfect. So PHQ-9 is kind of our screening for depression. And basically it kind of uses an acronym that we use in medicine, which is SIG-E-CAPS, which is kind of an acronym to kind of judge whether a patient has depression or not. So basically, what it is suicidality, decreased interest, guilt, energy, concentration. I know it's getting hard to see. Concentration, activity, so decreased activity, psychomotor, agitation or retardation, and I forgot the last one. I'm totally blanking on the last one. If anyone else knows it, put it in the chat. Oh yeah, decreased sleep. Nice, good job, Josh. Decreased sleep, yes. So that's kind of what we use. And the PHQ-9, I'm going to show you a slide at the end that kind of talks about it. And basically what it's saying is, you're filling out 0 to 3 and then tallying these things up. And based on the number, it can tell you kind of no depression, mild depression, moderate, or severe depression. Okay. So that's what the PHQ-9 is. There's another one for anxiety. It's called GAD-7. So it kind of judges kind of your anxiety level based off of that. And so that's how we kind of screen for depression, kind of at a basic level. And then obviously down here is our blood pressure categories in terms of hypertension. All right. So we're going to keep it moving here, and we're, good with time right now, but we have more. I think this is the last slide before we go into the cases. But colorectal cancer screening is fairly simple. And, what I want you to know is this is fairly new. And you'll see it here when this was implemented, May of 2021. That was, barely a year ago. And as you may or may not know, insurance kind of lags behind with all of this. And despite the fact that this is a pretty strong recommendation, this is a B recommendation, insurance still is not covering it, which is, it's kind of a tragedy. So what they're recommending is screening starts at ages 49 to 45 to 49, especially if there's risk factors. But this is kind of the gold standard right now, is this 50 to 75 in terms of colonoscopy screening. And when we talk about colonoscopy screening or colorectal cancer screening, we do have a few options that aren't the colonoscopy. But the one that's kind of the go-to is the colonoscopy. And you'll see if the colonoscopy is normal, and you'll see that in this table over here. If it's normal, we'll say come back in 10 years. Okay, we'll check again. If there's a hyperplastic polyp and if it's small, it's less than 10 millimeters, we'll still say, okay, come back in 10 years. But if we have low risk polyps or, they're tubular adenomas, which is a slightly higher risk, or sessile polyps, which mean they're kind of sessile kind of means they're kind of small and flat on the wall like that. We'll say, all right, that's a little more higher risk. So why don't you come back in 5 years? And then if we have higher risk polyps, and instead of 1 to 2 small ones, we have, 3 to 10, we say, all right, we need to increase the interval and you come back in 3 years. Then if we have more than 10 years, or we have multiple polyps, we might increase the interval even quicker, around the 1 year mark. And that's all you need to know. But the main thing is usually every 10 years if it's normal. And a lot of people have a normal screening, they'll come back in 10 years. And trust me, they won't want to come back any sooner anyway, because they have to take the prep, and they're it's not a luxurious procedure by any means, but it is certainly a necessary one. But when we talk about colorectal cancer screening, there are a few options. So obviously the first one is colonoscopy. We can also do other things like Cologuard, and that's like that test where I definitely spelled that wrong. Cologuard, where we take a stool sample, and look at and kind of analyze, their risk as a result. And that one is usually every 3 years if it's normal. Or the other thing is, which the drawback to this one is, if there is a positive, what are you going to have to do is the colonoscopy. So that's an important thing to have a discussion with the patient about, saying, if this test is in fact positive, I know it's easier, it's not as burdensome. You may not have to take time off of work because of it, but if it's positive, we may have to do a colonoscopy to sort of see if there is in fact a risk. Then the next one that we kind of can talk about is Hemoccult. Hemoccult testing. So what we're doing is getting basically doing a rectal exam, getting a little bit of stool from the rectal vault and rubbing it on a card, using a little bit of indicator, and seeing if there's blood. So does that tell us that there is cancer or not? If there is cancer, maybe, because not all cancers bleed. But a bad one theoretically will bleed, basically. But we know, you guys know, that you can get bleeding from the rectum, from the colon, for a multitude of different reasons: diverticulosis, hemorrhoids, many different things. So we're not relying on that test, but that one is yearly. And then the other one that we can do is flex sig. Sigmoidoscopy, basically, where we're looking at the sigmoid part of the colon, and Hemoccult, that's every 3 years. Okay, so these are our options. By far, colonoscopy is the preferred method, because you can see the entire colon, and you can see, all the way up to, obviously the part of the cecum. So that's definitely kind of the preferred method there. All right. Oh, I said this was the last slide. I keep lying to you guys. We still have more slides. Okay, so I think this is in fact the last slide. I may be lying again, but here's osteoporosis screening. We screen with a DEXA, and it's recommended in postmenopausal women younger than 65 at increased risk of osteoporosis. And the reasons why we do this is for women of whom may have a risk factor of osteoporosis, if they're on certain drugs, if they have a family risk factor, or if they had a pathological fracture. And what do I mean by a pathological fracture? I mean, they're stepping out of their car and they break a bone. Or they reach down and they get some groceries and they break a bone. So obviously, because of that decreased bone density, which is kind of this here, we see the normal kind of lacunae of the bone here and kind of those spaces in between. And then the bottom one, we see these big kind of wide spaces where there's not kind of that reticular meshwork of bone. Okay. And what do we call osteoporosis? Basically, what we say is that there's a few things that we talk about. So if the range on the score, which is we call this a T-score, and what a T-score is basically it's comparing, this patient to the average, normal bone density, basically. And what we're saying is if it's -1 and above, that's normal bone mineral density. And if it's between -1 and 2.5, we call that low bone mineral density, or in other words, osteopenia. So you may have heard that word before. And then if it's -2.5, which is kind of the kind of golden number here, we call that osteoporosis. All right. So I want you to kind of keep in mind those things. Mainly the big number that we're thinking of is -2.5, and they'll do it for different parts of the bone. So they'll do one at the hip, they'll do one at the femur. They'll kind of do that bone mineral density through a scan, through a radiologic scan, and they'll calculate this kind of T-score based on this patient, based on kind of the normal bone density, of an adult. And so when we get that ratio, it tells us, okay, is this normal? Is there a little bit of a little bit of that kind of breakdown of that bone, the osteopenia, or is this, osteoporosis? Okay. All right, we'll keep going here. There it is. Finally, we've made it to the cases. All right, so first case, if someone would read this, they're very brief today, so they won't cause you a lot of pain.
I can read this one.
Perfect.
A 66-year-old male with a past medical history significant for HTN presents for a routine physical. He has a 22-pack-year history of smoking and does not plan to quit in the foreseeable future.
All right, perfect. Thanks for reading that. So basically, this is a dude that has high blood pressure and he smokes. Okay. So my first question for you guys is his smoking history significant?
Yes, because it's more than 20 years.
Excellent. Good. And I agree. He has a 22-pack-year history, and you didn't even have to calculate it. They gave you it right in the vignette. And by they, I mean me. I was being nice to you guys. So they have a 22-year pack-year history, no plans to quit. So what is the guidelines? You guys tell me, what are the two things that I told you we need to remember? So we got the first one in terms if they're a current smoker, what is the threshold of pack years that we need?
Above 20, I also think is a good candidate because he's older than 65, which I think is also the threshold.
Cool.
Thanks.
Perfect. Yes. So, and that brings me to another one. So good. So we have so we got to look at this guy's age, and you're right. So we got to look at his age and his gender. Okay. So he's a 66-year-old guy. So we remember that basically, and which one was, you guys tell me, which one was, we talked about 20-pack year, and if they quit in the last how many years? Yeah.
But he didn't say he'd quit in the foreseeable future.
Exactly. Yeah. He's still smoking, but we know if he quit, 17 years ago, we would still want to, if he quit, 13 years ago, we'd still want to screen this guy. And what are we screening this guy for? What is the test? Yeah, it's a low dose CT scan for lung cancer. Exactly. So Adam, Rihanna, and Avin, you guys are all correct. Lung cancer, exactly. You're exactly right, Caleb. So this is a CT. We're doing a low dose CT, and we're looking for lung cancer. Exactly. Good. And then there's still one more test that we need to screen for, And to kind of piggyback off of that, do you guys remember the ages? He's in the range, but do you remember the age range that we kind of look at for these patients? And remember, they can be male or female in this one. It's always hard to remember all these things, but we're going to kind of go through them together. Yeah, 50 to 80, good. 50 to 80, perfect. And this guy can be screened for something else. He's a current smoker. Remember, we talked about that one, if they ever smoked, if they're a male, which is that one? Yeah, exactly. That's AAA. We're going to screen for AAA. How do we screen for a AAA? We have to screen for it, but how? Ultrasound. Yeah, exactly. We're going to do an abdominal ultrasound. We're going to kind of press, right below the sternum, kind of look at the abdominal aorta and see if there's any kind of aneurysm there, kind of a bulging of the aorta. Okay, to kind of keep it simple. I know when I was at your guides' level, I was like, I don't even know what a AAA is. It's like you just know these things and you just say AAA bad, but you don't know what they are. So basically the abdominal aorta is that big kind of tube that goes through your, through your body, and is the major source of blood to a lot of things. For instance, we know that the renal arteries come off the aorta. We know that some of the gonadal arteries come off. We know that the superior mesenteric, the celiac, and the inferior mesenteric, that's pretty wrong, but anatomically wrong. But all of those things, the celiac, the superior mesenteric, and the inferior mesenteric, that all goes to your gut. So the aorta is very, very important. It comes off, we know the aortic arch, comes off the heart like this. So basically what we're saying is if there is an aneurysm, it's kind of this bulging of the actual muscle layer of the aorta. And that's bad because once it kind of bulges like that, when we get that bulge, it has a risk of rupturing. And so that's why we want to screen for it, because it's deadly. And I drew this kind of down here by the aortic, the bifurcation here, because that is kind of the most common spot, is near the aortic bifurcation. Okay. So good. So AAA, and the AAA was 65 to 75. Okay, so you guys got that right. So the two tests that this guy needs to be screened for, and yes, he needs to be screened for high blood pressure, but he already has high blood pressure. That's the test we're looking for. We're looking for the AAA. We're looking for the lung cancer screening, particularly because he's a smoker. Okay. And in this image over here, I threw in a CT scan of a lung cancer. Hard to tell what this is. It is on the periphery. So maybe it's adenocarcinoma. We often say that squamous cell and small cell lung cancers are usually kind of central around the hilum, though this could certainly be anything at this point. We would have to get a biopsy to kind of know what that was. Okay, so good job. You guys said AAA screening with an ultrasound, 65 to 75, lung cancer screening with a low dose CT, 50 to 80 years, of whom had a 20-pack year history. And this seems like it's new in March of 2021, by the way, but it was just recently changed to be from 30-pack years to 20-pack years. So that's mainly the difference. It's still kind of the same recommendation in terms of everything else. All right, let's keep going. And let's get another reader if we can.
I can do it. It's a short one. 23-year-old female with a past medical history significant for asthma presents for her annual physical exam.
Perfect. Thanks for reading. It was a very short one. So yeah, you lucked out there. It was like a whole 12 words. Perfect. So we know, and I always kind of focus in on, okay, how old is the patient? And obviously what gender is the patient? And What we're kind of, and obviously if they have any past medical history, but what do you guys think? What does this patient need to be screened for? If anything, you can say nothing. But what are you guys thinking? It's a young female. What does she need? Yeah, good. So you guys said cervical cancer, pap smear. Remember, out of our options, so we are going to screen for cervical cancer. I agree with you. What tests are we going to do for it? You guys say pap smear, but what do we do? Remember, there's a certain age in terms of cervical cancer screening where we say, okay, we do this or this. What are we doing in this regard for her? She's 23 years old. So we are going to do a pap smear, but are we doing cytology? We're doing, just looking at underneath the microscope to see what's going on. Or are we doing also HPV, human papillomavirus? Are we doing HPDNA also?
I think I heard you're doing both.
So we have like kind of a mixed bag here in terms of the answer. So it is in fact cytology, and I'm going to show you the thing again here in a second, but we're going to write it out. So you guys are, a few of you guys are absolutely right. If you're wrong, I'm going to tell you why, and that's totally okay. These are very hard to remember. So from 21 to 29, we say pap smear, okay? And that, doesn't mean a lot because it's named after a guy. It's like papillonicula or something smear. It's like that. No wonder everybody calls it the pap smear because you can't say it. So basically what that is we're getting, a brush and we're kind of getting some cells off of the cervix when we're testing them. We're looking at them underneath the microscope, okay? And that's what that is. It's cytology. Cytology means looking at cells underneath the microscope, okay? That's what we're doing for women 21 through 29, okay? And then remember, our other age group is 30 to 65, all right? And what are we doing for those people? We're doing HPV, DNA, and cytology, okay? And you guys tell me, if the test is negative, how many years until they come back if they're 21 to 29? 3. Good. 3 years. Perfect. And then what about 30 to 65 if they have a negative HPV DNA and a negative cytology? 5. Good. Yes, 5 for that. And Caleb, you're right if they're only doing a cytology screen if you're 30 to 65. So remember, cytology alone, 3 years if it's normal. If the HPV DNA is there too and the DNA is negative, then we say, here's your 5-year ticket, come back in 5 years, okay? If you're 33 years old, then we only do cytology, then you're right, it is 3 years, okay? So 3 years with cytology alone. So that's the way to kind of think about it. Okay, anything else for this patient? What else are we screening her for, if anything? You could say nothing if that's it. Yeah, depression, hypertension, good. Yeah, you guys are right. Good, we're gonna screen for hypertension because she's greater than 18 years old, and depression, sure. And then remember, what is our test for depression? What do we call that again? Remember, alphabet soup. Yeah, there you go. Today's lecture is like alphabet soup city. Good, the PHQ-9. So you guys are absolutely right. With this patient, we're going to kind of screen for a few things. Hypertension, because she's 18 years or older, 18. Depression, all adults, and then pap smear greater than 21. Okay, and don't get fooled by like the 18-year-old of whom is sexually active. They still don't need a pap smear. You can do a pelvic exam if the patient has a concern about a sexually transmitted infection and you need to do a actual pelvic exam for a certain reason. Sure, they can do that, but an actual pap smear for cytology is not necessary in women, even if they're sexually active less than 21. Okay. And then down here, here's, as promised, the PHQ-9. And remember, this kind of, goes with our little mnemonic, SIG, E, caps, which, remember, stands for a few things that we'll kind of go through again for repetition. So this is little interest in or pleasure in doing things. So this is what this one is, interest. And then feeling down, depressed, or hopeless. So that is just kind of generally with depression. Trouble falling or staying asleep. That's kind of this one that I think Josh told us. Josh reminded us of that one. Feeling tired or having very little energy. That's for the E in SIGI caps, energy. Poor appetite or overeating. So this can go activity. Some people put activity and appetite kind of under this A. Activity. Feeling bad about yourself, that goes here with this guilty. Trouble concentrating on things, that goes here for the concentration. Moving or speaking slowly, that's this kind of psychomotor agitation or retardation. So it's kind of just feeling slow down, or some people have the opposite effect, fidgety and restless and kind of, all over the place. And then the other one is that suicidality one here. And do you guys know the #1 risk factor for suicide attempts? I guess there's kind of two. Yeah, it's gun ownership. Nice, Maddie. I actually don't know if your name is Maddie. I called you Maddie. I assumed it was. So maybe your name is Maddie or maybe not. But Madeline, it's gun ownership. It is a risk factor. And it is a risk factor. It's usually males of whom own a gun. And between males and females, who attempts suicide more? Do you guys know that one? So you guys are close, and that's another thing. Yeah, males succeed more, females attempt more. Yeah, good. So Maddie must be taking like a psychiatry class or like a psychology class, or she must like scribe in a psychiatric office, because you know a lot about psych stuff, which is awesome. So yeah, behavioral neuroscience major. So usually females attempt more and males succeed more. Yeah, that's kind of the thing. Perfect. Good. So we'll keep going here. If I can get my pointer out of the way. Oh, so here's our third case. If someone would read this last one for us. You guys are going to make me read it?
No, I could do this one.
Thank you. I appreciate it.
A 33-year-old female presents to her primary care physician concerned about her risk for colon cancer. Her father was diagnosed and treated with colorectal cancer at age 53.
Perfect.
When will she be due for colonoscopy screening?
Perfect.
Sorry.
Yeah. No, you're totally fine. Thanks for reading that. I appreciate it. So we have a few things going on. So we know that she's a female, but we know that there's no difference in colorectal screening between males and females. So that's something to hone in on. She's 33 years old. Her dad was diagnosed and treated with colorectal cancer at age 53. So what do you guys think? When is this patient going to be due for colorectal cancer screening? Anybody else have any ideas?
I think it's
we
the
have-
fact that her father was diagnosed with it at 53, so yeah, 44, 45, and she had to get tested 1 year, and she could use Cologuard or the regular one.
Right. So we have options, but if there is a family history, a lot of physicians will be more sort of weary and will want to just do the colonoscopy screening. And the patient will probably want to too, because they'll understand kind of the risks associated with it. So we have a 40, 45, and a 50. And I'm not even entirely sure that I had told you this kind of stipulation with colorectal cancer screening. So we'll be kind of going through this one together. And what is our guideline? Remember, our guideline is, we say 40 to 45 to 49 is recommended. And that's the new guideline, but our limiting factor is the insurance, but kind of definitely at age 50. Okay. But the kind of caveat, and I'm putting 100 stars here to say the caveat is if there's a family history. So what we say if there's a family history is 10 years before the family member was diagnosed, or 40, whichever comes first. And I'm almost 90%, I'm almost 100% certain I didn't tell you this, which is certainly an error in my part, because you guys wouldn't have known that unless you were reading through the guidelines. Whichever comes first. So that was like that moment where I stumped you all. And but for this patient, now that you know these guidelines, when is she due? So her dad was diagnosed at 53. She's 33. These are our recommendations. So based on all of this, when is she due for screening? Yeah, Josh says 40. I agree. It is 40. So basically what we're doing here is, if you guys are lost and you're like, oh my God, I have no idea what's going on, that's okay. We'll kind of spell it out for you here. So he was diagnosed at age 53. 10 years before 53 would be 43. Okay. And basically what we're saying is 43 or 40, whichever comes first. And obviously you guys should know basic enough math to discern that. You don't need too much math right now, but I hope you know that difference at least. And 40 comes before 30, obviously. So we're saying, okay, let's screen you at 40. Now, say this patient was their family member was let's say 64 when they were diagnosed at 64. The patient's still 33. When are they due for colonoscopy? Yeah. So still 40, because they're diagnosed at 64. 10 years before that would be 54. 40 still comes first. Okay. So that's basically the guidelines there. Say if this is a normal, healthy 33-year-old, no past medical history, no family history, when is this patient technically due for a colonoscopy? $45. Yeah, exactly. You guys are right. 45. And then say, it's a problem with the colon. Yeah, it depends on the insurance. It's exactly right. So if you guys learned anything, it's like, it depends on the insurance. So yeah, and I know that kind of, I was in a family medicine clinic all last month, and I was like, but the guidelines say, and it's like, well, no, it just depends on, if their, insurance will cover it or not. Because, you don't want to be stuck with a colonoscopy bill if, obviously there's not a sort of stratification of the risks. So, that's when you have kind of a candid discussion with the patient. You say, okay, you don't have a lot of risk. Your, insurance is not going to cover it. Do you want to pay out of pocket? Which, it's like $800, or depending on the center, basically. If it's a private center, usually it's cheaper than the hospital. But, at any rate, it's going to depend on if the insurance covers it. So, if they cover it from 45 to 49, perfect, go for it. But otherwise, definitely they'll cover it at 50. And that's when it's truly recommended. Okay, so good job with that one. I think that's our last case here, and we just, oh, that's where we talk about the thing. And I told you the kind of 10-year rule here, 10 years before the relative was diagnosed. And this, my friends, is a polyp here, and we're looking in the colon. And basically what we do is the GI doctors will kind of come in with this little lasso, and kind of, it's called they can kind of snare it here, go underneath in this lasso, kind of burn it off, pull it with them out of the colon, and then send it for testing to see if it, is a hyperplastic polyp, which is okay, or if it's an adenoma, which is not okay, or like a sessile polyp. There are certain bad polyps. If it's a villus polyp, that's bad too. Remember, villus is the villain. That's how I always remembered it in school. But there's certain risks associated with different types of polyps based on if there's dysplasia or not. But basically, we take those out, we kind of test them, make sure they're not bad polyps, and then decide when they need to come back. So good. Here we go. Last slide here. This is kind of just, a big chart that says here's kind of the recommendations based on, a number of different things, based on age, lots of different things. A few of these we didn't kind of talk about, but hepatitis B, syphilis, tuberculosis, these are all things, if they're at increased risk, test them. For HIV, it's recommended that you do it at least once in their lifetime. But often if there's an increased risk or a need to, then the provider may test it more often. Other things like obesity, hypertension, depression, USPSTF is saying, screen, regardless of age for a lot of these things, with the exception of HIV only at increased risk if they're older. And then there's other things down here, cervical cancer. We obviously talked about that one a little bit. Breast cancer, we talked about mammograms. We talked about abdominal aortic aneurysm. And we talked about colorectal cancer. So this kind of shows this big chart and kind of gives you the bigger picture, if you will, in terms of, risks of all of these things, including, diabetes and all these other things in context of age, which is always important because you got to know what age you're dealing with. You got to take it into kind of context of the bigger picture. Okay. So that's what I have for you. And before I let you all go, I want to give you the poll. I want to share it again, relaunch the poll so that you all can answer it one more time and tell me kind of where you stand in terms of your knowledge about guidelines now. And I know this was like, maybe perhaps not the most fun, but I think sometimes it's good to have an easier laid back one before we dive into something else. I think next time I'm talking about paraneoplastic syndromes associated with like cancer. So like the weird things that pop up in terms of, cancer showing up as something else, like small cell lung cancer often shows up with like hyponatremia because of SIADH, like syndrome of inappropriate ADH hormone or antidiuretic hormone. Awesome. So I think most of you guys are in. I'm going to stop it there so you guys can do what you do at night, go to sleep and do whatever you do. So it looks like most of you guys said some. I'm glad none of you guys said that nothing. I'd be like, oh, geez. I think you guys did well, and you guys kind of, really stuck with the guidelines because it can be hard to kind of memorize and stay with. And, when I first learned the guidelines, I swear I went cross-eyed looking at all of them. It's like, oh, geez. But, especially if you want to do primary care, these are a lot of the things that we want to kind of implement into clinic so that we're practicing more proactive medicine versus reactive medicine. Okay. So I'm going to stop sharing that. And that's it from me. That's all I got. So if you guys have any questions or anything about, medical school, about guidelines, about, match, about whatever you have questions about. I'll stick around for a few minutes and answer any questions that you have. Otherwise, I'll see you guys in, I think, 2 weeks. I'm not here next week, but the week after that, and we'll talk about some paraneoplastic syndromes.